Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the Depth Dive. Today, we're diving into a part of your body that's just, well, an incredible bit of engineering. Your abdominal wall. It's something we rely on constantly, but, hardly ever think about in detail.
Absolutely. It's this amazing structure for both protection and movement.
Right. And that's the fascinating thing. We want to explore this balance. How the very design that gives us flexibility, bending, twisting, also creates these inherent spots of weakness. Surprising, really.
It is a real paradox when you look closely.
So our mission today is to unpack all that, the anatomy, those critical functions, and how this design, this trade-off, can lead to things like hernias.
Exactly.
We want to give you those aha moments, help you see how it's all connected, get some clarity without, drowning in medical jargon.
A shortcut to understanding a key part of yourself.
Precisely. So when we say abdominal wall, people might think, core strength, six-pack abs.
Sure, that's common.
But it's so much more than just muscles for crunches, isn't it? What's really going on in that mix of muscle, bone, fascia? Why is it more than just a container?
Well, that's a great starting point.
Yeah.
It really is this complex structure designed for both strength and elasticity, balancing act. Its main job, number one, is protection, shielding all those vital organs inside.
Right.
But critically, it also has to allow for a huge amount of mobility. Think about it bending forwards, backwards, twisting, and even changing its size, its capacity. Like after a big meal or during pregnancy, it has to stretch. And that need for flexibility, for stretchiness, well, that's where the compromise comes in. It means it can't be rigidly strong everywhere.
Okay. So that's the paradox. The stretchiness affects the absolute strength.
Exactly. It's inherent in the design.
Okay, that makes sense. So if we think of the abdomen like a pressurized container, what are the boundaries? Like, what's the roof and what's the floor holding everything in?
Good way to visualize it. So the roof, essentially, is the diaphragm. That big dome-shaped muscle separating your chest cavity, the thorax, which has negative pressure.
Right, for breathing.
Exactly. Separating that from the abdomen below, which generally has positive pressure.
Ah, okay. Different pressures.
Yes. And that gradient is really significant. If there's a weakness in the diaphragm, like a hiatal hernia, that pressure difference can actually pull loops of bowel up into the chest.
Wow. Okay, so that's the roof. What about the floor?
The floor is mainly the bony pelvis, providing a solid base. But there's also a really important muscular component right in the middle, called the perineum.
The perineum, right.
If that muscular floor weakens, then things can bulge downwards. Organs like the rectum, the bladder, or in women, gynecological organs. We call that prolapse.
Prolapse. Got it. So roof is diaphragm, floor is pelvis and perineum.
In essence, yes. Those are the main boundaries holding that pressure.
Okay, let's zoom in a bit. If we could take a slice right through the middle of the abdomen, like a cross-section, what muscles would we see? How are they laid out?
Right, a transverse section. It's a really neat arrangement. If you look towards the back, the posterior side, the muscles there are pretty strong. They're supported by your spine, the vertebral column, your ribs, and the pelvis. But even there, interestingly, there are a couple of spots, the posterior triangles, that are naturally a bit weaker. You can get rare lumbar hernias there.
Okay, so mostly strong at the back, but tiny weak spots.
Correct. Then moving around to the sides, the lateral muscles, you've got three thin layers.
3 layers.
Yeah, and the clever part is their fibers run in different directions. They crisscross.
Ah, like plywood.
Exactly like plywood.
Yeah.
That gives it fantastic strength, but also allows for that flexibility we talk about. Twisting, bending.
Clever design. Okay, sides done. What about the front, the anterior part?
So anteriorly, you have the big vertical muscles, the rectus abdominis muscles. Those are the ones people often call the six-pack muscles. They run straight up and down from your ribs down to your pelvis. Very powerful muscles. And here's a key point. Hernias don't really happen through the main body of these rectus muscles themselves. They're too strong.
Okay, so not through the muscle. Where then?
The weakness is usually where they meet in the middle. There's a fibrous band, a seam, running down the center called the linea alba.
Linea alba, white line.
Literally, yes.
Yeah.
And that central seam is a natural area of, well, relative weakness. That's where you tend to see epigastric hernias higher up, or umbilical hernias right at the navel.
Okay. That makes perfect sense. It's the join, not the muscle itself.
Precisely.
Okay, that actually brings up something I've heard people ask about and get confused about, devarication of the recti. Is that the same thing? Is it a hernia?
Excellent question. Very common point of confusion. No, it's definitely not a hernia. Devarication is when that linea alba, that central seam, stretches sideways. So the two rectus muscles, the six-pack muscles, move further apart. You see it often in the upper abdomen in middle-aged men who might be carrying a bit of extra weight.
Right.
And in women, you see it below the belly button, often after pregnancy, because everything is stretched so much.
Okay, so it's a stretching and separation, but not a hole.
Exactly. There's no defect, no hole for things to protrude through abnormally. It's just stretched tissue between the muscles. And the crucial thing is, because it's not a hernia, it usually doesn't need any treatment. Sometimes surgeons might offer a repair for cosmetic reasons, but it's not medically necessary.
That's a really important distinction. So devarication is just stretching, not a hernia needing fixing.
Correct. It shows the body's ability to adapt, really, like during pregnancy. It's not necessarily a failure.
Okay, super clear. So putting devarication aside, let's get back to actual hernias. What is the fundamental definition? What's actually happening when someone has an abdominal hernia?
Right. So fundamentally, an abdominal hernia is when an organ, or maybe some tissue, pushes out abnormally through an opening or a weak spot in the layer that's supposed to keep it contained.
Okay, like that tire analogy, the inner tube bulging through a weak spot in the pyre wall.
That's a pretty good analogy, yes.
Yeah?
And when this happens, the bulging tissue or organ takes the coverings of the abdominal wall with it. They might get stretched really thin, but they're still there.
Okay.
And an interesting detail, not all abdominal hernias start with what we call a peritoneal sac. That's the lining of the abdominal cavity.
Oh.
Yeah, some hernias, like many epigastric ones, might start as a little bulge of fat just within the wall layers.
Yeah.
The peritoneum only gets drawn into it later as the hernia gets bigger.
Fascinating. So it's not always the inner lining poking through right away.
Not always, no. It can be a bit more gradual.
Okay, that definition helps. And it really reinforces that this isn't just about, lifting a heavy box one day, though that might trigger it. There seem to be underlying anatomical reasons, vulnerabilities built into us.
You're absolutely right. While lifting or straining can be the final straw, the potential is often already there because of our anatomy.
So what are these sort of anatomical trapdoors or weak points? Where does this vulnerability come from?
We can group the main anatomical causes into, let's say, 4 broad categories.
Okay.
First, there are areas of just natural weakness where the muscle layers are inherently thinner or absent. Second, you have natural defects, openings that are supposed to be there to let structures pass in or out of the abdomen.
Right, like necessary passageways.
Exactly. Third, there are developmental abnormalities, things that didn't quite form correctly before birth, so congenital issues.
Okay, present from birth.
And fourth, you can get disruption of the abdominal wall from injury, like surgery or trauma.
Injury. Got it. Okay, 4 categories. Let's unpack those. What about the first one, natural weaknesses, where muscle is just thinner?
Yeah, inadequate muscle coverage. The main examples are those lumbar triangles we mentioned earlier in the lower back region.
Right, for the rare lumbar hernias.
And also the posterior wall of the inguinal canal in the groin. It's just structurally not as robustly layered there.
Okay. And the second category, natural defects, the necessary passageways.
This is a big one. These are openings that serve a purpose, but because they are openings, they inherently create a potential weak spot.
Makes sense.
The classic example and the most common site for hernias overall is the inguinal canal.
The groin area.
Yes. In males, that's the path the testes takes when it descends from inside the abdomen down into the scrotum, usually around birth. It brings blood vessels and the spermatic cord with it. In females, a structure called a round ligament runs through there.
So a necessary tunnel, but
it creates a potential space, a pathway, for an indirect inguinal hernia to form. It's fascinating. Actually, studies show the risk is higher in people with a wider, shorter pelvis shape. The anatomy matters.
interesting correlation. Are there other examples of these natural openings?
Oh, yes. The esophageal hiatus, where your esophagus passes through the diaphragm to reach the stomach, that can lead to hiatal hernia. The femoral canal, another spot in the groin area, just below the inguinal ligament. That's where femoral hernias occur, more common in women.
Right.
And even the umbilicus, your belly button. That's the remnant of the umbilical cord attachment, the umbilical cicatrix. It's a natural weak spot where umbilical hernias can pop up.
So lots of points where things are meant to go through, creating opportunities. Okay, third category, developmental issues, hernias from birth.
Exactly. Congenital hernias. These happen when something doesn't quite close up or form correctly during development. The most common one, again, is the indirect inguinal hernia. It happens because a little tube of peritoneum, the abdominal lining called the processus vaginalis,
Processus vaginalis.
it's pulled down with the descending testes or round ligament. Normally, this tube is supposed to wither away and close off completely after birth.
But sometimes it doesn't.
Exactly. If it stays open, even just partially, it leaves a direct path from the abdomen down the inguinal canal, ready-made for a hernia. And there's some interesting recent research suggesting certain peptides, like calcitonin gene-related peptide and hepatocyte growth factor, play a role in whether that tube closes properly. It hints at maybe a hormonal influence in some cases.
Wow, so body chemistry might even play a part.
Potentially, yeah. It's an active area of research.
Are there other congenital types besides inguinal?
Yes, though less common. You can have congenital diaphragmatic hernias like Morgani or Bachtelek hernias where there's a defect in the diaphragm from birth. And some umbilical hernias are present right from birth, sometimes alongside other congenital conditions in newborns.
Okay. And the last category, acquired weaknesses from injury, like surgery.
Yeah, disruptions from injury. Surgery is the big one here. When you have an operation that cuts through the abdominal wall layers, even if it heals perfectly, the scar tissue that forms only ever regains about 70% of the original strength of the muscle it replaced.
Only 70%. Wow.
Yeah. So there's always an inherent weakness there. This leads to incisional hernias. We see them in at least 10%, maybe more, of larger open abdominal surgeries, what we call laparotomy incisions.
1 in 10. That's quite high.
It is. But the good news is, with minimally invasive surgery, like laparoscopic or keyhole surgery, the incisions are tiny. Those little port site incisions. The hernia rate there is much lower, maybe around 1%.
Ah, big difference.
Huge difference. So as we do more and more laparoscopy, we should hopefully see the overall number of incisional hernias decrease over time.
That's positive. What about non-surgical injury, like accidents?
Direct damage from, say, blunt trauma, like a car crash or severe tearing of the muscles. It's pretty rare, actually. You generally need exceptional force to cause that kind of disruption leading to a hernia. It's not a common cause compared to surgical scars or those natural weak spots.
Okay, that paints a really clear picture of the different ways these vulnerabilities arise. So we've taken this really fascinating tour, haven't we? Through the abdominal wall, seeing its strength, its essential flexibility.
And how that very design plus development and injury can create these weak points leading to hernias.
Yeah, and what really stands out, I think, is that the body is just this amazing example of balance and compromise.
Compromise, yeah.
It's constantly trading off one thing for another. The abdominal wall needs to protect and allow movement, and that involves creating these inherent vulnerabilities. Hopefully this deep dive has given you a better sense of those, hidden complexities within your own body.
Absolutely. So as you go about your day, maybe just think about this. Our body's designed this brilliant balancing act between being strong and being flexible. It automatically creates these specific weak spots. It makes you wonder, doesn't it? What other parts of the body might have similar trade-offs, similar compromises for function that we just, never really stop to consider, something to ponder?
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.